Good morning, everyone, or good afternoon now. I'm Steve Sunderland, as introduced, the director and co-founder of the Cancer Justice Network. We are a private, not-for-profit 501c3 here in Cincinnati. We're 9 years old. And if I have any goal for this particular talk, it would be that you would write down our telephone number, 513-404-3882. And the next time you're thinking about going to a doctor, or if in fact you are seeing a doctor, you might want to think about whether or not a navigator would be someone who could accompany you and be an ally, an advocate, to accompany you through every stage of whatever the particular illness is. We started with cancer, and we have broadened out or branched out to every major health issue that there is. I want to talk for a few minutes about the Cancer Justice Network and my own personal connection to it, and then have two of our veteran navigators talk about their experiences as well. And then we'll answer questions or have comments from everyone who would like to make those kind of comments. So I hope you will think hard about what we need in terms of personal health care as well as social health care. And our feeling is that we are at a crossroads, that healthcare is so broken in our community as well as in the country that without an ally that goes with you, you are liable to not only receive no care, but perhaps a mediocre care or poor care. I have been stunned by the demographics of our community, where life expectancy is so different. There's a 26-year gap. We heard from Kate Schroeder of Interact for Health the last time we had the forum, between various neighborhoods. And so you can't see it, but there's a handout which looks at neighborhoods that are predominantly African-American with those that are predominantly non-African-American. And we see somewhere between a 10 and 25-year life expectancy difference. This has been a pattern in Cincinnati for a long, long time. It's a pattern that's unacceptable. It's a form of accepting systemic racism in a way that is frightening, that we are willing to accept a life expectancy based on both geography and social conditions. If you live in Hyde Park, which is only a stone's throw from Avondale, the life expectancy should not be 26 years difference. There should not be the loss of life as extensive as it is. So I'd like to talk a little bit about this. I'd like to start with a story. We all have a story about healthcare. We all have a story about hospitals and doctors. And the story starts with something like, I believed I was safe. I believed I was safe when I sought a doctor, when a doctor suggested a health procedure, when a hospital entertained my different condition, when a nursing home took my loved one in. I believed that, in fact, I was safe in those choices. And in fact, the quality of medicine was so good that I really didn't have to worry about a great deal. 9 years ago, I had the misfortune of having cancer in my family from two family members. And we went to try and find out where was the best cancer treatment in Cincinnati for my wife and then for my brother. And we could not get a clear answer. 6 hospital systems in the city, all of them said that they were the best. All of them said that they could do any kind of cancer treatment that's possible. No outcome measures, no quality measures, no indications of specializations that they felt were really important. This worried my wife and my brother and myself. We were people interested in, as a university professor, I was interested in how people made decisions about what was the best treatment, what was the best place to go. Every hospital had a banner outside of it said, we're the best, but they didn't say what they were best in. So on that journey, we talked to a lot of people. We had a lot of second opinions, and we were very confused. I did my own research and found a program in New York developed by a person who went from Howard University to Harlem Hospital in 1985 as a cancer surgeon. And he found that for 5 years, most of his patients died. Over 70% of his patients died. They died because they came too late for cancer care. They died because he could not do any surgery because they had reached the stage of the 4th stage. So what he did was he turned to the community, found community activists, called them navigators, and had them go into the community to talk to people and say, come early. If you have a concern about your health, if you think you have cancer in your family, if you know people who are in your family who have died of cancer,
it's okay.
Then Ed Burdell is here using his left hand for some good reason, I'm sure.
I was taking the laser dot off your face.
Oh, thank you.
Nobody thought that you were going to be.
I thought I was part of a Hindu tradition there. So navigators were used in the community to bring people in sooner. And in 5 years of study with navigators, he was able to turn mortality upside down. So instead of 70% of the people dying, 70% of the people lived. He then continued his research and published it and became the first African-American president of the American Cancer Society. Harold Freeman, his name is. He's the grandson of a slave. Dr. Freeman was lucky enough to know President George H.W. Bush, and President Bush appointed him to a commission on inequities in healthcare. A law was passed indicating that they needed to research the navigation effort. And for the next 5 years, research went on all across the country in terms of how good is it to have a navigator? What does a navigator actually do? How does a navigator work? Why does a navigator make a difference? And was it just a unique difference in New York, or does it happen nationwide? And what they found was that navigators were the critical difference in terms of people living, that people would not have their care delayed, that people did not get confused by what a doctor said was their treatment, that people were not postponing their treatment, they actually were complying with their treatment. And when he looked into those who were underserved the most, African Americans, Hispanic people, and Native Americans, he found that those populations were the most in need of navigators in terms of making sure that the hospitals and doctors treated them appropriately. So Dr. Freeman's research was just like a bolt of lightning to me when I was looking at it in terms of my own family. I called Dr. Freeman on the phone and I asked him, where's our navigation program in Cincinnati? Our statistics for minorities are unbearable, unbelievably large. Where's our navigator just for normal operations in terms of cancer? And I said, we don't have a single hospital that has a navigation program. Would you come to Cincinnati and talk to the hospital CEOs, talk to nurses and social workers, and talk to our group about navigation and why we should have a navigation program here in Cincinnati? He agreed. And he came 9 years ago. We had a wonderful conference. We had many of the hospital administrators of every hospital in Cincinnati, probably with the exception of Children's. And we had a wonderful discussion of the research on navigation, showing that navigation didn't cure cancer, but it raised the probability that people could survive cancer because they came early in the stages of cancer. So before Dr. Freeman left Cincinnati to return to New York, he said, you have to implement this program. You have to find a way of starting a program at one of these hospitals to have navigation. Actually, all the hospitals should have navigation. And I said, thank you for your suggestions and your consultation. We are very excited about what you presented. We are thrilled to try and do this. We're sure we can do something with the hospitals. So the medical director, Nemat Mousavian, and myself of the Cancer Justice Network went to every hospital, and every hospital said, what a brilliant program, what a beautiful program. We don't want it. And we said, why? It certainly can make a contribution to the stopping of cancer. And it certainly would have helped those populations that are the least served in Cincinnati. And basically, in one form or another, they said, that's not a population we're really interested in. Good morning. Dr. Mousavian has just come in. Have a seat, Dr. Mousavian. So we are talking on a Zoom and in a conference as well. And I'm just mentioning that Dr. Freeman had come to Cincinnati and met with us and urged us to go to the hospitals and get a navigation program, and that you and I had gone to the hospitals and were turned down by every single hospital. Nonetheless, we decided to go ahead with the navigation program. We decided to find people who are community activists. We asked one of the social work professors at UC who had been trained by Dr. Freeman to work with us. We asked Dr. Mousavian to help us in the training process for navigators. And 9 years ago, we had a training program that then started a navigation effort. We then decided we would go to churches and community centers and senior centers all throughout the city, primarily where there were minorities or seniors or people with disabilities, and talk to them about cancer prevention. And prior to the COVID explosion, we were taking about 200 people a week to hospitals for exams, to dentists, to eye exams, to hearing exams, and so forth. The COVID experience shut everything down. And now we have reopened, and we have come back to Christ Church Cathedral to work with their Tuesday night program for low-income and homeless people. And we are working with a coalition of organizations throughout the community, trying to bring education about navigation to every community, every church, every synagogue, and every mosque. Because we think that if in every institution there were people dedicated to advising people on getting the best health care, on going with them to make sure that the health care was given in a respectful and competent way, that navigators could also make sure that people actually met their appointments, that they went, if they had to go for chemo or dialysis or any kind of issue for heart disease, that they would be going with someone and someone who would be caring and supportive. And finally, we decided that we needed to help people with transportation. The biggest barrier, the biggest obstacle to getting to cancer care was that people could not afford transportation to get, nor was there kind of a transportation system in the city that went directly to the hospitals. So we have invented a hospital transportation system. It is free to every person who works with us who would like to go for any kind of health care as well. So we have moved in a way that has made navigation a primary effort for us in terms of healthcare for the city. We have said that it's critical for particularly the underserved. It's critical to change the statistics about mortality. It's critical for us to begin to have a city where peace can happen in the city, where health is a part of a peace effort, that we can have not an acceptance and acknowledgement that there is a terrible situation going on for many neighborhoods, but that we say we're going to do something to change it. And navigation is the way we're approaching it right now. So what I'd like to do is have you meet two of our navigators who have been our most experienced people, who were with us almost from the very beginning. One was there at the very start, as well as our medical director, and have them talk a little bit about what they do. What are the steps after someone calls that 513-404-3882 number? What happens then in terms of how a navigator can become a person who works with that person for free, works with that person through every stage of their cancer or heart disease or diabetes or whatever the particular health situation is, helps to arrange transportation, helps to arrange daycare, helps to arrange kind of respectful experience by the health professionals themselves. So let me introduce, do you have a microphone yet, Pat?
I think Brian's working to do it. So for the time being, probably best to change seats.
Yes, if you would come up here, Pat, and sit here. I'd like you to meet Pat Youngblood, who has had a lot of experience prior to coming to the navigation program at UC. She's a wonderful community organizer at Peasley Center for Community Center in Cincinnati, and she has been a rock solid person for navigators. Let me leave this chair.
Don't try to jump over the wires.
Okay.
Sorry,
Okay.
I will do the Olympic leap.
Hello. My name is Pat Youngblood, and I have been a navigator with the Cancer Justice Network since it started, according to Steve, about 9 years ago. I just want to say that I got involved because when Steve was explaining to me his concern about low-income people or underprivileged groups not having access to the best health care. Having worked in healthcare for over 30 years, I thought, well, that's very true. I've witnessed that quite a bit. So my first thought was, okay, so how do we go about this? And when Steve explained about the navigators working in the community, I thought, what a great idea. However, you know, you don't just walk up to a person and say, I want to talk to you about your health care. Because we all know we would say, what are you talking about? And be very opposed to that. So it took us a while to understand that in order to make this happen, we had to build a relationship with the people we were trying to work with. And that we managed to do by working with Christ Church Cathedral through its dinners on Tuesday night with homeless and underprivileged people of the city. I found that if we could make these people understand that we were not there to tell them how to live their lives, only to help them understand that their lives are just as important as anyone else's. That how they felt about healthcare should be important to everyone, not just to us, not just to them, but to all involved in healthcare. So I made a decision that if I was going to be a part of this program, my part would be not only to give information, but to make the people at these dinners understand that we all have the right to healthcare and to the best healthcare we could get. So my first and foremost goal, I guess, was to make the people that I talked to understand that I wanted to get a better relationship, not just talk to them about their healthcare, but to understand what prevented them from getting healthcare. And so today, 9 years later, I think we've done some of that, but we're still, as Steve said, he and Dr. Musavian talked to all of the hospitals. We cannot get hospitals involved with us And that's very sad. Having worked at University Hospital for over 30 years, I know that things are not always as well as could be expected. But I hope that after 9 years of doing this, we will be able to help other people understand that it's not just about giving help, but it's about building relationships with everyone to make sure that everyone has access to not only healthcare, but to any opportunity that we can get for them. And that's why I'm here today. Thank you.
Could you introduce Jada?
So now I'd like to have Jada come up. She is another navigator who has worked with us almost since the beginning of the program. Thank you.
Good job. Hello, I am Jada Davis. I'm a navigator with Cancer Justice Network. I've been with the organization since 2018. I started off as it was an internship or externship program that I had to do through Cincinnati State. And once I came on board, it was wonderful. It was wonderful. I mean, we were out in the community. We were meeting with people. We were providing information. We were building relationships. That's one of the most important things we do. And one of the most important things we have to do. We have to build trust and relationships in the community. As Pat so said, you know, you just can't walk up to people and say, well, let me hear about your health or what's going on with you. We need you to go get some screenings. Have you had any screenings? You have to build relationships. And that's one thing that we do. And we see people through from start to finish, whatever medical needs they may have, whatever medical relationships they may have in the hospitals, in the doctor's offices, in the clinics, in every aspect. I've talked to a lot of people who has had the diagnosis of cancer. And one thing that I hear from everyone is how they're taken aback from that diagnosis. And they get the diagnosis at the doctor's office and then they're sent on their way and we'll be in touch with you. And I can't imagine having to go home and deal with that diagnosis. And there's nobody there to talk to, nobody there to share that with. I have sisters who have had cancer. And they told us, you know, they come home and say, well, you know, they say, I got cancer. And fortunately, they had the supports there. But I've talked to many people who told their family, and everybody is stunned. Everybody is, you know, taken aback by that information they just received. And nobody knows what to do next, where to go, what to even think about the information they received. As a navigator, we do not give medical advice. We are not medical people, but we do offer supports. If we can find out what you need to know, we're there for you. Sometimes people just want to talk, just you know, well, I've never dealt with this before. You know, what am I supposed to do? We are there to help guide them through the system, be it support systems, the hospitals, any treatments they may have. You know, we're there for their support. I have plenty of stories to tell about mistreatment from medical people. I have, you know, we deal with a lot of low-income people or homeless people. And I was homeless, and I wasn't homeless. I was low income. So I know the treatment that they get when they go into a place, maybe not with the right insurance, or maybe with not the right zip code, you know, and we are there to advocate for that person, be it mistreatment, be it better healthcare, or, you know, what can we do next? As Steve so said, you know, where do we go next? Or what is the best possible solution for this person, despite them not having the right zip code, the right healthcare? So we are there to support a person throughout the whole steps of their medical diagnosis. And I said this the other day, a lot of times we may meet someone with cancer and they may get through that. We may be successful in helping them survive that cancer, but then they develop diabetes or heart disease. We are there for those things too. It just doesn't stop or start with the cancer diagnosis. We're there to help anybody who needs any navigation. I don't even like, I'm not gonna call it navigation, any help getting through the healthcare system. We are there to guide them, support them, and give them any type of resources they may need. I know someone right now is facing eviction. We are there to help them through this medical issue that created this domino effect for them. We don't have resources, financial resources, but we do have resources. And we work with people throughout the community to help people get what they need and live productive lives, because any diagnosis is a stressful diagnosis, and it creates a lot of stress on people, on families. So we're there to help in any way we can.
Could you introduce Dr.
And here's our medical director, Dr. Namat Masabian.
Thank you very much. Can I say a few words?
Yes, please sit at the chair.
Thank you. Good afternoon again. It's a pleasure to be here. I'm sorry I was late. My name is Namat Masabian. I'm a gastroenterologist. Also, I have training in nutrition. I could tell you till tomorrow morning what I have seen, what I have suffered, and how much I have been surprised about the lack of healthcare for large component of the population in this country. This is the United States. It's the best country in the world. I have been almost all over the world. And there's no place of medical care here as far as for people who could afford. But there is a large number of population.
A lot of distrust, as we know, in our communities, and everybody in the community has something to say about whether or not they want to trust the government or trust the medical procedure or trust the hospitals itself. So we are trying to say to people, work with us, we will work with you. There can be a trusting experience that goes on. We can ensure that you will get respectful treatment and you won't be alone in this process when you go to a hospital, when you go to a physician, when you go to a clinic, when you go to a health center. We are trying to form a coalition of churches and synagogues and the mosques to say to people just what you're asking. Everyone in these houses of faith should be on Medicaid or Medicare. Everyone should be aware of what their rights are in terms of health care and health insurance. So we're absolutely determined to do that. And of course, Medicaid in this state is different from Medicaid in other states, but we have a very good Medicaid program here. But how do people get access to it? We have to help them with that situation. Thank you for the question.
Thank you, Brent. As a follow-up, people from all demographic levels unfortunately believe that the shot process for COVID is some kind of government hoax or worse. And there must be resources available to convince people that there's a medical basis for the treatments. And I'm wondering if we know what those resources are and if they can be used to educate people so that they don't make a decision based on fear or prejudice, but upon actual science.
Excellent question, Tom. Thank you. 2 years ago, the CDC Foundation in Atlanta asked us those same set of questions, and we were very happy to be the recipient of grants 2 years ago and last year to try and work on this issue of persuading people that there is science, that the science is evolving, it's changing, but there is a science that we can trust. And we have done vaccination events here at Christ Church. We've done it at the Church of the Resurrection. We're doing it at Greater Missionary Baptist Church. We've done it throughout the city in terms of trying to persuade people that these vaccinations are sound. They're not the end of the process. They're just one step in the process on the way to boosters. So the CDC itself is confused about how to overcome the distrust that's in this area, how to overcome the fact that people don't want the vaccinations. We still have tremendous mortality amongst underserved people in terms of the vaccinations. We did 52 people, had 52 people vaccinated here 2 weeks ago at Christchurch Cathedral. It was a great experience. We had that large number because people trusted the process. So we are engaged in people, with people to try and figure out how can we take the steps that are necessary for their health, their long-term health. And Dr. Mousavian raises the critical point. It isn't a one-shot experience. It isn't a one-time only. It's a continuation of healthcare as their problems develop and as they need help themselves. Dr. Freeman has shown that people are trusting when the care is reliable and it is competent. And so we've been very successful with that. Dr. Freeman continues as a friend of our program as well. Please.
Thanks for your question.
We need a microphone.
Very valid and very timely. Actually, to be honest with you, the effort should come from the federal government or the state government, that they tell the people that, you know, the importance of vaccination and how to fight against COVID. Also, along with that, then they could say, hey, take care of yourself. If you have diabetes, you have high blood pressure or whatever. But this really should come from, at least from each state government, overall from the federal government. Like CDC says, I mean, here there's this fragmentary type of thing, and people forget. This is a really big and huge issue, which is very important, could reduce mortality, could improve the quality of life for people.
In your experience, is the community generally aware that the shots are free? The problem is access, but the vaccinations themselves are free. Have you found that people know this? They don't have to pay for it? People
do not know this. They think they will be stuck with a bill. Again, this is part of the communication process, part of building trust with people. The great fear is, particularly amongst low-income people, is that they will be hit with a large bill. We try and persuade them that it is free, it's being offered, and this church has offered gift cards to Kroger's as a part of the process as well. We not only want to say it's free, we want to say we want to give you a bonus as well. So, but again, we're facing a hospital system, a medical system that is fee-based, and people are aware of it, and they can't afford it. But we say to them, it is free, and they say, but what do you get out of it? And we say, we get healthy people out of it. That's our goal. It's hard for them to believe that.
I have a question in chat. Navigators seem to be community organizers too.
Please speak a little louder, please.
Okay.
No, I said please speak a little louder.
Louder?
We want you to speak
okay.
up.
Navigators, I'm afraid I'll get an echo here, but navigators seem to be community organizers too. What do they do when they experience others, communities, problems? For example, guns, gun violence. Are there other NGOs that you also work with? There's another question also on the chat.
We have built relationships with Talbert House, with a number of different organizations in the community that are concerned about human service issues, such as violence and such as gun control and things of that nature. But we're trying to beat the drum about health and health care. As it overlaps with the issues of violence, of course, we're interested in that as well. But right now, we're trying to raise consciousness about the fact that everyone deserves the right to health care. So is there another question?
Yes, there is another question.
Thank you.
Do you have a definition of healthy neighborhood? That is one of the major and city council priorities.
Yes. there really is no one good definition of a healthy neighborhood, but we feel that every faith-based institution should be part of the healthcare network, that there should be facilities in churches, synagogues, and mosques for doing diagnosis, for doing blood pressure examinations. We're even seeing in some communities around the country, people doing cancer care inside of churches and inside of homes as well. So a healthy neighborhood is one where there is a consciousness and a health literacy, where people say, I want the best healthcare in this community, and where the institutions of that neighborhood, whether it's a school or a church or a senior center, are advocates for that person to get the best healthcare by providing the healthcare themselves in the neighborhood. We're in the future of healthcare, and the future of healthcare is not hospitals. The future of healthcare is not nursing homes. The future of healthcare is in the community. It is the community agencies that are going to make a difference. We're going to put some kind of diagnostic program inside of Christ Church Cathedral as a model. We're going to put it inside of the mosque in Clifton. We're going to do it as well in other communities and in the Church of the Resurrection. We want people to come into a church environment or a synagogue environment or a mosque and say, I'm here in good faith and I want good health as well. So yes, a healthy neighborhood is not having a hospital in your neighborhood, because hospitals have turned their backs on the neighborhoods. A healthy neighborhood is a neighborhood that is active and literate about health education. Robert Harris is here. Robert Harris's church, People's Church, has already made a commitment to healthcare inside the church. Robert, could you tell us a little bit about that?
Well, the commitment is real. Chris Beard, the lead pastor there, has said to me, make it happen. And so that's my marching orders then as part of the membership drive, not to just bring in members, but to let them know, to help them to understand that whether they have a disability or don't have a disability, whether they're Black or white or some other ethnicity, it doesn't matter. They have a right to health in their community. And they have told me that I can make it happen. So I'm going to make that happen. And one of the things that I didn't realize that other people, other churches are doing this. I have been asked if I would come to a church on this Saturday because they're doing an entire, from 2 o'clock on, an entire service dedicated to people who are in the church and who are in their community in Anthony Wayne, that will let them know that they are welcome and worthy in God's house, and that involves health, health, health. So I'm happy to be able to report that, and I'm telling you that you know it, and I really thank you, Steve, and Dr. Masanya, and all of the folks who are here for acknowledging that, and now we just have to make it happen and not look back. So thank you, all of you, for keeping on. Thank you.
Thank you, Robert. I think the next step that I would say would be that when People's Church is now designing a brand new church, in that church will be a health center. In that church will be something that will be absolutely connected to healthcare. This is the future. That's what a healthy neighborhood is. Tom, go ahead.
Steve, if you would, I think another common concern or fear is confidentiality. People are reluctant to share their health issues for fear that it gets back to certain parts of the government, that they'd rather it be private. Would you address your policy on that, please?
Yes, our policy is that complete confidentiality. We want to respect the HIPAA requirements. We want to make sure that people have their medical records completely trusted, and we will not share our records of what we're doing with people with any organization at all. So we prize privacy, we prize confidentiality. We make sure that people are committed in our staff to making sure that people's information is kept clearly under wraps, so that there's no question that that's going to be a trusting relationship. So as we move forward, the ways we're moving forward in terms of neighborhoods, we're building this coalition across neighborhoods, particularly the neighborhoods with the worst health insurance, the worst education outcomes, the worst life expectancy. We are going to build those communities as centers of healthcare. And we're going to find in a short period of time, we hope, that those mortality statistics will change radically. Yes.
I'll talk loud. Steve, what is the size of your population, your staff? And then how are you funded?
Thank you. We are 12 or 13 strong navigators, 1 medical director, 5 gold rings, 4 calling birds. Holiday season gets me right there. And we have been blessed by being funded by a wide group of organizations, including the CDC Foundation, including OKI transportation monies, Interact for Health transportation monies. This church has also helped us as well with transportation monies. And we have a substantial grant from a Catholic organization in Cleveland, the Congregation of St. Joseph. We are very, very happy to say that we're receiving funds. We're trying to hire more navigators for more faith-based institutions as well. So we are, we're 12 strong right now. Another question on the Zoom?
Obviously, you're doing very important work here at the center. What would you like to leave us today with next steps you want to achieve in 2003? Where are you headed? We've already talked about that to a certain degree, but since we're beginning to wind down, we wanted to give you the last chance to tell us what the next steps are.
Well, the next step, I thank you very much, Bill, is please think about a navigator for yourself and your healthcare. Please give us a call if you have questions about navigations at 513-482-4. I've lost it in my head. 404-3882, 513-404-3882. And ask us any questions you have about what it would take for you to have a navigator. We are free. There's no charge for it. There's no charge for the transportation as well. Well, if you're interested in having your church participate with us, or your synagogue or your mosque participate with us in our Coalition for Health Justice, we would love to hear from you. So we see a coalition as our next step, a coalition that can raise to the entire community the central points that we've talked about today, that navigators can make a difference in mortality, that we cannot ignore any longer the poor communities of our city and the communities that are suffering most in terms of mortality. And lastly, we can, in fact, raise the educational quality about healthcare for everyone. We can tell everyone what the warning signs are, not only of cancer, heart disease, diabetes, sickle cell as well. We can educate the congregations to really being aware of how healthcare is so important and how they can get their healthcare, not just know about it, but take action with us. So again, we thank you for the opportunity to talk with you about this.
Actually, we will be delighted to hear from more communities, more people, more organizations that want to expand and spread the knowledge about healthcare in general. This is what we are really trying to do. By doing that, 2 things happen. We cover more people as much as we can, and also the people get more knowledgeable about their health, because this is at most important. As a physician, again, I have seen so many patients, they have diabetes, heart disease, this and that, they have precancerous lesions, but they don't know the importance, how they are dangerous. I mean, it's very common, unfortunately. This is something that we want to focus on, that too.
Thank you. Yes.
One last question that I'm just going to ask, because I think it's important, and I want to hear again what you said about it. How did the hospitals explain to you why they weren't interested in your navigation program?
Well, that's a very important question. We have talked to the CEOs of the hospitals. We've talked to the heads of cancer programs. We've talked to people at every hospital, including children's. And the basic response is, these are poor patients. These patients are not good patients. They don't really comply with what we need to take place. They don't really come regularly when they should. We don't want to have a special program in this area. So we said, well, we can do something in just this neighborhood. Every hospital in the city is connected to a neighborhood that has these terrible statistics. Couldn't we do something in that area? And they basically said, no, we're a national hospital. We're world famous. We don't work in Mount Auburn or Avondale or these other areas. I said, well, let's just come across to a church. Let's just talk about warning signs of cancer or warning signs of heart disease or lung problems. We can't do that. So the COVID experience changed that somewhat. Hospitals became overwhelmed with everybody. And now we think this is the future. The future will be the hospitals are unprepared for everyone, not just poor people. So the question now comes, not just triage, who is served by the hospitals, but the question is, can we create in each neighborhood, in faith-based institutions, in senior centers, in community centers, can we develop a network of health experiences for people that keep them healthy and not depending on the hospital? If the hospital does not want to change its attitudes towards low-income, poor, and homeless people, people with disabilities, women as well. Recently, a study came out that something like 50% of the women who go to the emergency room do not get treated in the same way as men, irrespective of race, irrespective of class. So we have a confusion going on in the hospital. So we want to offer an alternative. We want every faith-based institution to be a node of healthcare, a center for healthcare. And if we can do that, hopefully the hospitals will follow us, or we'll have a different future for healthcare. It may not involve hospitals except for some special conditions. But right now at Harvard in Boston, at New Haven where Yale is, at the University of Pennsylvania, they are moving cancer programs into faith-based institutions and homes. People are doing chemo in homes, and it's called hospitals at home. So we are so far behind the curve in terms of what a healthy neighborhood could be, what a healthy home could be. So we have our work in front of us, and we're excited about it. We're enthused about it. And our staff is just wonderfully connected to it as well.
If I may add a few words, I think Steve really hit the core of the problem. And the question is, if, like Steve said, we don't do in a generalized basis, just fragmentary, I think a few people here, few people like the clinic, things like that, it won't work. So this is what we are trying to do.
Yes.
Thank you.
Thank you all very much. Been a wonderful forum. We will be back in January on the 12th. So we'll be back at this spot on the 12th with a new set of forums, and we look forward to seeing you.